All right.
Hey everybody, I'm Mike DesRocher. I was just thinking about it. I've been a nurse just under 40 years. I got my degree in fisheries and wildlife management, and it's worked real well in nursing. That's actually what I went to college for. I promised I would never work indoors. And I had a great job out in Montana, but the federal government shut down the jobs, and so I had to go back to school on the Junior Mill. Got a nursing degree to kind of get me by for a year or two. That was because RNs got paid $1.75, and the LPNs only got $1.10. And really, that's how the wages were back then. And the average guy in the factory was making $7, $8 an hour. But anyhow, I survived. I'm going to retire in about 3.5 weeks. And I managed to make it this far and still be above ground, and still having fun. Okay, I'm a neuroclinical nurse specialist. Back when I went to school back in 1980, the clinical nurse specialist was the trial of getting into the nurse practitioner stuff, but we were hospital-based. And so as a hospital-based, we were trained to work within the hospital system, prescribe within the hospital system, do everything within the hospital system. And one of the goals was to make the system work better. And so there was this thing of, okay, what can we do to the people to make sure they have less infections and all these other kind of things, move through the hospital faster and safer? And that's really what our jobs were about. And about 7 or 8 years later, they stopped and went to nurse practitioners who do a lot of training in offices, but don't get that much hospital stuff. So I got basically almost an MBA in business management for hospital type stuff. But it's been great. I have never had a job. I have enjoyed coming to work every day for 55 years. Since I was 10 years old, I always liked working, and I had fun, and nursing has really been pretty fantastic. And I'm going to tell you guys something up on the 6th floor. You guys are on the 6th level. I tried it. It was 5th floor at the hospital I was at, and it was general med surge, and it was a jungle. Almost every night on my way home, I thank God I didn't kill someone. Because there was 1 RN, 4 LPNs, and a bunch of nurses' aides, 50 patients. Pharmacists left at 3 o'clock in the afternoon, and all the stuff was in the cabinets. You had to mix all your own drugs, you had to do everything. And I didn't kill anybody. I honestly, not one patient died because of me. A lot of patients died, but not because of me. And so you just, in hospitals, people get pigeonholed into just orthopedics or just neuro or just something else. And it's very hard to do your job because it isn't straightforward. You can't put everybody on the assembly line, which is almost what you can do with the surgical, some of the the surgery programs, the orthopedics, the neurosurgery stuff. Day 1, day 2, day 3, day 4. Your patients just don't match that. Okay, your patients are going every which way, and they're not necessarily going in the right way on every day. And they usually are more complicated. I mean, people say, oh, the most complicated patients are in ICU. No, the most complicated people are those ones that don't get to ICU that you guys take care of. Okay, you don't let them fall off the cliff and go to ICU. So I have the greatest respect for the general med surg folks. I went to ICU, and it was so easy. I only had to count my 2 patients at the end of the day, and they were both still breathing. The ventilator was still working or whatever. Right? So my measure of success was different, but I'm really proud of you guys. You guys do a fantastic job. Okay, to get started with the stroke stuff, I handed out, this has been sent to all the doctors about a year ago, and I think we're doing pretty good. It's called permissive hypertension. It's a separate page. And it's some of the great things we found about stroke since in the late 1980s, early 1990s. We found out that people didn't have to go to nursing homes. And when I started, it was over 50% went to a nursing home for every day the rest of their life. Okay? We get people that leave here, we get some of them we know are never going to go home from the nursing home. It used to be most of them. Never did. And so we were looking at the things we did. One of the things, and we didn't figure it out until after the year 2000, that if we let the blood pressure run up to where it scares us, they're going to do better. Okay, if you're looking at the blood pressure and you're scared to death that blood vessels are going to break, that's the body's natural defense for a clot in the brain. For ischemic stroke, the natural defense is to raise the blood pressure because you're getting swelling in the brain. Okay, you have to somehow, once the pressure inside of that swelling gets to a certain point, that area is all going to die. If you can let the blood pressure rise, what will happen is it will keep that area, keep the blood flowing through her, and there's GABA, and instead of lactic acid, they got GABA, everything else in your brain. It clears that stuff away and decreases the size of injury significantly. Like you can almost, if they can handle the blood pressure, if the heart can handle it, and if their kidneys can handle it and everything, it is good to run. And we've had a couple people here, we let run at 220 over 120 for a day and a half. And they walked out of here talking, and they came in here looking pretty terrible. It's scary to us, it's scary to patients. Hypertension causes strokes, but hypertension also saves you if you have one. Okay? So just be aware of this. This is not a hard and fast rule, but you have to be open-minded to the concept. And you have to watch out for the first couple months when the new medical students come in. It's a little scary, because they want to bring them down to 110. And we worked with Longpre on the one patient that was on 3, and every time the night person would bring the lady down to like 140, she would just droop right out. You know, and so they would call the person in Chicago back then. The person in Chicago said, well, let the blood pressure rise a little higher, get rid of the blood pressure medicine. And sure enough, within an hour, she'd be up walking the hall talking and doing everything. She was at 190 to 200, she was perfusing the brain that needed to be perfused. So, but you still, some people's hearts aren't going to be able to take that. And you don't just have bad blood vessels in one part of your body. It's not just that one in your leg. You know, the patients that we see, it's not just that blood vessel. If you have one bad blood vessel, all of your blood vessels have injury to them throughout your body. Your coronaries, your carotids, everything else. So blood vessel disease is systemic. It's everywhere. And it is hard to pump against pressure. And so the heart just has to pump more. So be aware. They're going to be trying to do stuff. Don't let them get too crazy. The research shows that you should not correct their blood pressure by more than 10% per day. So if they're 220 over 120, you bring them down to 210 or to 202 over 105. You don't bring them down to 160 right away, or they'll infarct like crazy. You bring them down slowly, and they do better. But they have to have a good heart. They have to have a heart that can do it, and that's one of the tricks of it. It's called permissive hypertension. It's a fantastic thing. So we'll talk about strokes. It's basically a disruption in blood supply to a part of the brain. It can be from a clot. The most common is people with atrial fib. They'll get a clot in their heart, and the clot will take off and go up to their brain, plug in the vessel, and that area downstream does not get blood supply and starts to die. When that happens, all the collateral flow from the other parts of the brain, every part of your brain has 2 ways that the blood gets to it. Okay, you got overlapping blood vessels from the anterior cerebral to the middle cerebral and to the posterior cerebral. When they come up, they branch out like a tree and they overlap each other. So if you lose blood supply into an area, it's going to start having trouble, but the other blood supply is going to help it from totally infarcting and dying. And that's part of why the permissive hypertension works. What you do is you push it in from a different angle. And the blood clots a lot of times will dissolve away on their own. We talk about TPA and $3,000 a dose and everything else. You produce TPA every day. Right now, I guarantee you're producing it because you're awake. When you're asleep, your TPA production goes down. And they found the TPA back in the 1980s in humans, and they wondered what its function was, and they found out it's got this cycle that higher during the day when you're active, lower when you're not. And then we're starting to realize that everybody has blood clots in their body on a normal day. It's just they're not moving and doing things, and your body's just dissolving them. So you're forming clots because you got your knee bent too much, you open it up, you don't necessarily get it. It just kind of dissolves it away. And it does it instantly. You know, heparin and Coumadin and the anticoagulants, you take them, they stop the clot from growing. Your body's TPA over the next 2 months comes in and dissolves that clot away. So, you know, but the Coumadin and that stuff can only stop it from expanding, from the clot to grow. clots want to grow, and they'll grow lengthwise down through the vessel, and they'll cut off all the new supplies and everything else. But we used to sit and watch them. They would be bad, and then they'd be worse, and then they'd be even worse, and then they'd be worse, and then they'd go off to a nursing home. It was, at one point in time, they said, why don't we just take them to the funeral home? Because there was nothing we could do for them. And we were actually dropping the blood pressure back then down, thinking they had to have normal blood pressure. It made them severely worse. Right, I just saw an article now, the average person who has a stroke is much better off. Over 50% of the people that would have gone to a nursing home no longer go to a nursing home. And it's usually where they go to a hospital that doesn't know how to care for them and drops their blood pressure down and does all that stuff. All the research is out there, everything's out there doing it right, and our hospitalists and intensivists do it right. So, and with atrial fib, you form a clot, there's a left atrial appendage. Has anybody heard that? You hear it from the cardiology folks. Since the echoes have gotten really good and they can take MRIs of the heart and everything else, they found by the aortic valve, there's a little spot that there's a little indentation into the heart muscle that looks like a reverse appendix. And blood flows in and flows by it and everything else. And for some reason, every now and then it'll form a clot and send a clot out. And so they sometimes will see, when they're doing their studies, they'll actually see the clot in the left atrial appendage. Not everybody has them, but most people do. And so they found this other area where somehow your TPA isn't getting to it on a normal day, and so it goes to clot, and then it takes off and goes. An atrial fib, the whole atrium is sitting there just not really pumping. It's just gravity's moving things by it. The atrium is not pumping anything when you got atrial fib. And so it gets pumped up, the back pressure pushes it forward, it doesn't push itself forward. Okay, and then on the heart valves, the heart valves can get clots on them and throw clots. And one of the other ones, and I don't know how often we see it anymore, people get vegetation on their heart. They get endocarditis, and if infection's not treated, sticks to the valves and lives for years. So that's why you have to finish your antibiotics. You know, you don't just take them till you're feeling better, you got to take them all the way out. So you can knock out, and it depends what disease you're going after. Sometimes it's a 10-day course. Don't stop at day 6 because you feel good. Because some of these infections get your heart and cause you trouble. And the vegetation actually will take off and go up to the brain. And sometimes by the time we see that vegetation will be forming an abscess. Because it's still a live bacteria that was sticking on your valve when it went forward. And it's called vegetation. Your carotids, they're the bigger vessels. They get a lot of rough spots on them because of cholesterol and everything else. And in those rough spots, clots can form and take off and go. You can also form a thrombus just about any place. Generally, for a thrombus to be stuck to a blood vessel, and we're seeing the new CAT scanner they put in a couple months ago, they're actually seeing the thrombus in the blood vessel if there is one. And it's usually the middle cerebral artery. And you can get a pretty good sized clot in there just like you do in your leg. But it's in the artery. Okay, it's an arterial thrombus. And it sticks to the wall, and then sooner or later it'll break loose and it'll tumble downstream. And as it breaks up, little strokes will occur. So there is such a thing as getting thrombus in your brain, definitely in your carotids. And wherever you form cholesterol, wherever the cholesterol sticks to you. If you're a smoker, you are overworking your blood vessels because they shrink, go up and down all day as your nicotine levels go up and down. And what it does is it scars the inside lining and allows cholesterol to stick there. It's not because you ate fatty foods. It's usually your own cholesterol that you're producing yourself, but it sticks to the walls of the vessels, and it thickens and thickens, and sometimes that'll even break loose and go upstream or downstream. DVTs in the legs. If you were born with a hole in your heart, as you should have been, or she probably wouldn't be here, the patent ductus is supposed to close, and the septal defect is supposed to close. For that fetal circulation is supposed to close up. It looks like maybe 30% of the people never closed. And it wasn't we couldn't pick it up until we did really tight diagnostic tests. Now the average test can tell you if you got a hole going from the right septum, or from the blood's going from the left to the right, but you got holes in your heart, hold up in the atrium, atrial septal defect, and your patent ductus. A lot of people have it. They went in and started treating them about 5 years ago, caused a whole bunch of people to have strokes by doing it, caused a whole bunch of problems, and they kind of backed off. But they used to think all of them need to be repaired, so they came up with this neat little gadget you put in and go up into the heart, and they had a screen, and they put the screen up in place and blow it up, and then the screen would form a clot, and then that area would close off. They're not doing it anymore, and I think it was because there was just too many complications. But you can actually get a clot in your leg, and when it goes up, there's no direct path for it to get to your brain. It gets to your heart and gives you a PE. Because it gets stuck in the capillary networks, and it gets stuck in there, and you get your PE. If you have a hole in your heart, though, it actually can come from your leg, go up through your heart, and up to your brain. And they're usually a lot bigger strokes. They go up, and you know, some of these people you say, you know, what do you got? Oh, geez, you know, we ran on a trip a couple months ago, and I've had this pain in my leg. I've been rubbing it all the time. Just like they told us to do as nurses, rub your painful legs and see if you can get those clots moving. But so the DVTs can also. You see, and blood vessels will deteriorate, and if you read the reports, you hear, well, we don't see a stroke, but we see massive small vessel disease. Small vessel disease in the heart and it causes a lot of lacunar infarcts. You see those words flying around. Small vessel disease is when the terminal blood vessel going out into the brain or into the heart muscle or anything else. The terminal ends of it with cholesterol and everything else, they'll just gradually close up, and you won't even notice that the area is dying. They're little teeny pinpoint areas in your brain where the brain has died because of lack of blood flow, because the small vessels are clotted up. They almost never give you enough to know that something's going on. Some people, they're finding some of the dementias just have massive small vessel stuff. It was basically cholesterol plugging up the smallest vessels and causing damage to the brain. And so it's one of those things that that's dangerous. But small vessel disease is happening in everybody. The average person used to live to be 60. When I was a kid, you lived to be 61. I made it. I'm not going to die young. And now the average person is going to live to be in their 80s, okay? So if you wonder what's happening to the economy and all the stuff that's going on, it's because of all these programs and pensions and everything else. And now we got, instead of giving people, the average Social Security person as of 1972, only 50% ever got a check. They put into it every day they worked, they put the money in and never got anything out because they died before 61. Starting in the 1960s, we started really improving the quality of life, length of life. And so now we got to send checks out to everybody. And that's what goofed up Detroit, Flint, Grand Rapids, that's what goofed up the school districts, the federal government. They just figured with Social Security, well, we'll give them 1 or 2 checks, they're going to croak away anyhow. So we don't care. Well, blame your doctor for keeping you healthy, okay? And it truly is what's happening economically and everything else in this country. Okay, for prevention, stopping smoking is the best thing that you can possibly do. Ottawa County now is at 12%. It was at 34% in 1980. It's now down to 12%. Kent County is at 15%. Some of the places in Flint, Detroit, Saginaw are still over 20. But nobody's at the 30% mark anymore. And it's pretty fantastic. And then taking it, you talk to your doctor and things, but just taking a baby aspirin a day and Plavix or Agrinox, one of those anti-platelet medications, do fantastic things. The 81 milligram aspirin a day probably saves 10,000 strokes a day. There's no doubt in my mind. It just, because the clot just won't form. The platelets won't stick together. It keeps them so they can't.
Which age would be taking the aspirin?
I started at 40 because of my family history. It comes down to family history and those kind of things, but the 81 milligram aspirin is pretty safe for anybody. It's not going to cause you to bruise and all kinds of stuff. Once you get up to 325, it's bigger. I take 325. Dr. Altman has been keeping track of his patients with strokes and stuff, a neurologist, and he notices very clearly the people that took 2 aspirins seem to be doing better, so they've talked him into going up to 2 aspirins a day. Now, if he gets a GI bleed, 2 325s a day. He knows that someday if he gets an ulcer and it bleeds or something, he's up a creek. But it's just thinning down your blood that little teeny bit with an 81 milligram aspirin. The Plavix works very good. The Agrinox is just Plavix, or it's just aspirin and one of these very old medications they put together. Now they charge $200 a month. But it makes all the difference in the world. Don't be afraid to take it. Ask your doctor, and if you got a family history, if anybody's had a heart attack in your family before the age of 60, you should be thinking of what's happening with your blood vessels. You know, if they're blood relatives, you should be checking it out. The lipid management diet, the low-fat diet kills people, and it's not good for people. The American Heart low-fat diet, and many people have admitted that they caused the obesity epidemic in the United States. We moved from a relatively high fat, we're still a relatively high fat diet, and we've pushed in carbohydrates. When you're taking carbohydrates, it increases your hunger and really runs your pancreas crazy. And so we had that up to like over 60% of our diet if you were a good hard diet person. But the more you take carbohydrates, the more you have to take. So you got to be one of those people that grazes and eats all the time. If you take in proteins and fats, they digest slower, and it's not as bad for you. So they're backing down on most of the high-fat diets. They're not going against them anymore. They know the trans fats are a problem. They don't know the other ones are. The biggest problem is probably your own genetics, because you make cholesterol in your liver, okay? But what you want to do is you want to keep your blood vessels good and healthy so it doesn't stick. You know, you want lots of HDLs, so it'll keep everything cleaned up. Aerobic exercise, the best possible exercise for most people is walking. If you can get walking and just get to the point where you're just barely sweaty, you know, you don't need to get running or anything else, maybe breathe a little bit hard, you just push yourself a little bit and a little bit more every day, you can actually clean up your blood vessels. There's research from Blodgett from years ago and everything else. They found the people that came in and went on the treadmill 5 days a week for 20 minutes, and they recatheterized, and they saw that their blood vessels were getting better in their hearts. So you can do it, you just have to get out there. In weight management, just try to eat smaller portions. And try not to make it all carbohydrates. And by the way, chocolate is a carbohydrate. So even if you cheat with it, okay. So you normally want blood pressure down below 140 for about 90% of the people. If they're diabetic, you want it below 130 or so. Diabetics are damaging their blood vessels all the time. Once their blood sugar gets up to 200, 250, it is just eating up the inside lining of your blood vessels and allowing cholesterol to settle in. And it breaks down the blood vessels in your kidneys. It breaks down everything. So the diabetics really have their issues, and their blood pressures do need to be lower. And they do need to be on antiplatelet stuff if they want to survive. Early mobility, while they're in the hospital. DVT prophylaxis, you know, the heparin and sequential stockings. Prevent aspiration pneumonia. It used to be over 25% of stroke patients had aspiration pneumonia before they left the hospital. And they used to stay about 6 or 7 days. And most of it was from laying flat in bed. So all you do is bring up the head of the bed, gravity will help the fluids go down. You produced 400 milliliters a day of saliva and mucus. There's always stuff running down, okay? So no matter what you do, you can't stop the stuff from coming down. I always get a big kick out of it. You know, well, you can't let them eat that, you can't let them do that. Well, believe it or not, they're swallowing their snot. Stuff can go down into the lungs. But it used to be very common. Since you guys have been doing dysphagia screens, and it's been 10 years, well, actually 13 years since the dysphagia screen's been used, we've had 2 people get aspiration pneumonia while they're here with an acute stroke, out of 1,500. 2 people we have it recorded, and it's amazing. It's just by raising the bed up, so the gravity will get the saliva flowing the right direction. And elevate the head of the bed. Do what you need to get them comfortable. And we like starting nutrition as soon as possible. Some of the hospitals are almost immediately starting people on high nutrition, high protein diets and different stuff. From our side of things, because of the dysphagia screen, we start people out on liquids, and usually by 24 hours they're up to real food. where some hospitals can't get a speech therapist to come in and they won't use the dysphagia screen because it's too complicated, the one you guys use. It's so terrible. It's so terrible, it's unbelievable. But in a lot of places don't have speech therapists. Every Monday and Thursday they have speech therapists coming through their hospitals up in the UP and all through the Plain States. The speech therapists stay where the customers are, and they're by the big cities. Yes?
I have a question on the higher protein stuff for our patients that are here. It seems like with stroke or whatnot, but our diabetic snacks are so much, just seems so high carbs. And
Yeah.
I know, why
Yeah.
didn't we do cheeses and stuff?
You know, and I think these dietitians, you know, they've got doctorate degrees and everything else, and they learn the low-fat American Heart Diet. And it's very, very hard for them to look at the new research and say it's true. It's very, very hard to look at something that you have told 400 people a year that they have to do this to save their lives, and you find out, well, maybe it's not. Maybe it's not right. Doctors find out usually within 2 years when they're giving people medication and it's killing them, and they stop it. You know, because a lot of the stuff gets on market before it should. So, you know, but the nutrition people really thought they had it all figured out. What I think medicine and everybody else is figuring out is every human is different. We treat every human like they're the same. And you can take cholesterol and you're going to be just fine. Well, the other person's not going to be. You know, we got 300 million different species in America, okay? Because we're all different. We get a lot of stuff from the family. You look at your family history, it's going to determine a lot of what happens to you. From the cancer side of things, the heart side of things, and everything else. Okay, and avoiding injuries. Use the gait belts. Before nurses were allowed to use gait belts, and only therapy people could use gait belts, I bet you I saw 10 dislocated shoulders on the patients. You start to go and you hold on to them, and they can't fight against you, and you dislocate their shoulders. And I tell you, it's one of the worst things in the world to see is some poor person, you help them to move, and you just dislocated their shoulder, and that's a 10 out of 10 pay. And I haven't heard of one here in recent years, and I think it's because nurses could use gait belts. Okay, reasons for elective intracranial surgery, and you guys are seeing more and more things. Tumor removal or tumor biopsy. Okay, the most common tumors are glial tumors. The glial cells are not the nerve cells of your brain, but they're the structure. It's like a cobweb all over the place, and the brains go in and out through the glial stuff. And it keeps the shape of the brain. But the nucleus is over here, and the cell is over here. They're like big long strings with a nucleus at one end and the other. So no matter what you do, you cannot win if you got somebody with a glioma, because you cannot remove both sides of the brain. They've tried removing half the brain, and their death rate comes exactly at the same time. Back in the 40s and stuff, they just removed half the brain, saying, well, we'll get it. The cells are all over here. No, the glial cells go back and forth all the way across. And they're usually terrible. They start out at grade 1, and sometimes you'll see a grade. I've seen 1 or 2 grade 1s, and I've seen thousands of them. You know, thousands of tumors. Grade 2s, you see some in children. They have a tendency to move up to grade 3s, which is relatively active, and then the grade 4s are the glioblastomas. They're reproducing cells every 6 hours instead of every 6 weeks, and they're reproducing themselves so fast that they overcome. The other ones that are there's one that's relatively nice is meningioma. Meningioma is an outgrowth from the dura, from the meninges, and it grows into the brain. Or it grows on the surface of the brain and pushes the brain out of the way. So when you go in to do the surgery, and Dr. Figueroa he can go any place, and Clark, they can go any place around the brain, they can take it right from the top, and they can take it out. It used to be every craniotomy was right frontal. And because you couldn't tell, because you made the person a different person by retracting the brain out of the way. And that's where your personality and all that stuff is. And so people look good to us, they would walk and they would talk and they'd be okay, and then the family would come to the office and say, God, he is weird. He hadn't been that weird. He curses when he didn't used to curse. You know, he's impulsive, he's got all these kind of things. And so the way they're going at it, going in all these different places to enter the coronial, it's making such a difference because they don't have to retract so much brain. So you can leave the rest of them. But the meningiomas, they call it shucking it out. You open it up and you open up the dura and you get down in and you open up around and you pop it out. Because it doesn't grow, the meningeal cells do not grow into the glial cells. So it's a separate thing, but it's pushing the brain out of the way. And the biggest one I've seen was probably that big around, right between the frontal lobes. And I saw the woman a year later, she was doing fine. She never had a neurodeficit at any point. She had a seizure, that's why we found it. Got a scan on her, and sure enough, there was a big spot of water there. The brain never reshaped. The brain has, and your spinal cord and everything else has neuroplasticity. So if you put pressure on it over a long period of time, it'll keep functioning by redoing its cellular structure. So it's plastic. So I've seen probably 20 or 30 MRIs of the spine where we couldn't find the spinal cord. It went in surgically, and they're walking, they're playing sports, they're doing whatever. And as you're opening in, you can't find an opening where the spinal cord is. And so it's just basically beating right at the arthritis. But it just came on slow. It came on slow enough, and they call it a ribbon cord. And it looks like a ribbon, and when they die and they resect them, sure enough, everything's kind of lined up just right, going up and down. So pressure on your brain over a short period of time is a problem. We'll talk about that with emergencies. Okay, and then they did an AVM last week, I think. They do aneurysms on a regular basis. The AVMs are arterial venous malformations. You end up seeing it start usually even right after birth. If you MRI every brain, you find quite a few people have AVMs. It's where an artery is pumping out pressure of 110. It's going into a vein that's got a pressure of 0 to 5. And it goes down the venous structure, goes out. Over time, the vein will not bulge out like an aneurysm. An artery with all the muscular walls and everything else bulges out. The veins keep getting longer. So if you put too much pressure in the vein, it just keeps getting longer and longer and longer. So when you go in surgically, it's like a ball of spaghetti. And they dissect back to find out where the artery part was, and they tie it off one side, go to the other side, and take off the venous side. But sometimes it can be 3 foot long in your brain. And it just kept pushing the brain out of the way over time, relatively low pressure. And the worst ones, I think, are when you find them in kids and they're big. And I've seen a couple in the under 15 age grade. For some reason, they just don't do as well with them. If they catch them before that, or if they catch them when they're 40 or 50, and you don't have to do anything about them. They don't rupture very often. They're more likely to bleed in an accident and stuff, but you've got artery pumping into vein, high pressure into low pressure, and it stretches out rather than bulge out. Okay, the other things going on in town, and some of it may be starting here, they do surgery at St. Mary's for Parkinson's disease. They do deep brain stimulation. They go down through and they drill a hole in and they put it down in, and they can use fetal tissue. They can use all kinds of, I think they can use your own tissue. They can take muscle from your arm and implant it in your brain, and your Parkinson's goes away. They're doing the research, and it's working on some of the people at least. And they're doing surgery to stop seizures. And it's very effective. So, and there's one, it's the vagus, they have a vagus stimulator that they put in the neck, which I think is very interesting because they don't have to go into the brain. And they wrap this coil around the vagus nerve, which comes down and gives you your vagus stuff, your blood pressure dropping. It makes your stomach acid. The vagus nerve goes every place. It's your eyes, your stomach, it's your bowels, it's everything. And what they do is they put this device like a pacemaker on. And what it does is, as soon as the seizure starts, the electric spikes come down and hit this thing, and it sends back exactly the opposite electric spark. So it's going all the time. And so people don't have seizures. In town, I know there's at least 75 people that go to one clinic that have not had a seizure since they put the vagus nerve stimulator in. Now, it's not inside the head or anything else. It's just in the vagus nerve that comes down and covers your heart, and it speeds your heart, slows your heart, does all that kind of stuff. But it can pick up the difference in electricity and sends back the opposite message. There's somebody bright out there. We don't know exactly who it is. Okay, the emergent craniotomies that we're going to see, and I think we're going to start seeing them ICU says the traumas are getting more complicated. More multi-system problems, they're finding renal failure, they're finding all kinds of stuff. Once you stabilize them, you find lots of stuff. Subdural hematomas is a hematoma between the dura and the brain. So it's still inside of the dura, and it is 99% of the time it's a venous hemorrhage. So what's happened is some of the veins are broken and it's bleeding out, and it's kind of dripping out. It's not going very fast, it's a vein. Then there's the epidural hematoma, which is between the dura and the skull. And it's usually if you get hit laterally, if you get hit broadside and go sideways back and forth, there's, on both sides, there's an artery that goes from the bone to the dura, on both sides. And it's the middle meningeal artery. And when the brain goes over the side, it'll rip that artery. The artery, if they don't die before you get there, I mean, you could be 2 minutes away, they would be dead because they're bleeding from that artery. If they do okay, then you have to watch them very, very carefully. Anytime they say they have an epidural hematoma, it could be the artery. And I've seen them crash. I've seen 2 crash right in front of me. One pupil blows, they say, I feel crummy, and they're down. And you can do surgery on them. And you can do surgery on them without anesthesia. And it works. You drill a hole in, you let the blood out, and they wake up, and then you have to go fix it. And one guy I worked with he was just that cool about it. No, you gotta get a drill, come on, get a drill. He blew that pupil, I'm gonna drill a hole over here. Sure enough, drill a hole. This was an ER, and they're all looking at him like he's crazy. They got an ortho kit. He was, but yeah, so the epidurals can get you in a second. They can go into spasm, and a spasm release 12 hours down the road, and you die just as quick. Arteries go into spasm when they're damaged. And so the epidurals have to be watched closely. And generally, within a half an hour, you're dead. If you can somehow start draining and get the pressure off the brain, because the brain will herniate right down because it's had arterial pressure. Interparenchymal hemorrhages, you see those, that's the hemorrhagic strokes. Hypertension usually, blood vessels weaken and they blow out. And some, for emerging cranium, sometimes there are masses that are growing too fast. Some of them, the metastatic tumors and stuff will get up in there in the brain, and they'll really pick up a nutritional supply, and they'll start growing quick. And so they'll actually take them to surgery. Don't schedule for next week. They'll schedule them for next hour. Chiari formations. You guys have seen Chiari formations. You've seen the lumbar drains and all that kind of stuff. Chiari formation is something that happens at 8 to 12 weeks inside of the uterus. Okay, and it's something with the way the embryo forms, and so it's there from life. And what it looks like on a scan is when you scan through the foramen magnum, you got your foramen magnum, the big hole going up into the brain, and then it hooks onto the spine right there. And you rotate around very nicely. And the brain stem is right almost in the foramen magnum. It's just a little bit above. And what happens is the cerebellum, intermittently, as you move around, and will start to herniate down. Not because it's swollen or anything else, because it's formed funny, and then the bones are formed funny. So you got your cerebellum, and the one that Figueroa did was all the way down at C2. The cerebellum from the brain was down there, but had a humongous foramen magnum, and a C1 that fit right. I mean, so these are congenital abnormalities, and they're not usually death-defying. The patients feel very, very sorry for them. They've been telling their mothers and their grandmothers and their teachers and their preachers and everybody else, I got this terrible headache, I'm gonna vomit. And they vomit, and I'm like, she's just that way, and wake up in the middle of the night with pounding headaches, and then walk around and they go away, because they are kind of gravity related, and they aren't believed. And then when they have their surgery, when they find out what it is, the whole family, everybody that's told her she's crazy for 20 years, wants to be in the room at the same time. Okay, because they all want to say they're sorry, but they don't know how to say they're sorry. But nowadays they would pick it up probably in the ER. They wouldn't have 20 years ago. But it's terrible to not be believed and be told you're crazy. And especially when you're told you're crazy many times and your family doctor charges you $100 and still calls you crazy. You know, so be aware there's a dynamics that goes with it. I very seldom I've seen, there was one recently that was normal. She was totally normal, had normal activities, had her headaches. She would just lay down when she had her headaches. She'd be back out doing stuff. She was in 2 or 3 weeks ago. And nobody was going around, oh, poor baby, or anything else. And all she wanted to do was get back out, get on her bike, and get doing stuff. But most of them are debilitated because of the way people treat them, but they are evidently very painful. They goof up your circulation of your CSF to your spinal cord and everything else. And it depresses the brainstem. It can cause you sinus bradycardia, it can cause you all kinds of stuff because it's pushing the brainstem. So, okay. Elective spine surgeries. We'll go through it quick. Lumbar laminectomy, you guys know, 99% of them you see here, the reason for a lumbar laminectomy, and you guys don't see them anymore because they're downstairs. They're down in surgical outpatient stage, just a simple lumbar laminectomy. They go in, take pressure off a nerve, and get out. Every now and then, they'll actually get back pain relief. Almost no surgery gives you back pain relief, okay? So you can believe anything you want. They got a 97% chance of taking away that pain to your leg or pain down your arm. It's up there almost 100%. They can take that away, they can take the pressure off the nerve. They can't, even if you fuse a spine and you put screws in it and everything else, fusions, the people will still have pain there for some reason. Because we always think the pain is because related to motion, and it's not always. So that's like a 60% chance if you fuse it that your pain will go away. But what will happen over the next 5 years, the vertebrae above and below will take on extra wear and tear because you got one that doesn't work. And so then you get pain at those levels. So the surgery for back pain is not good. Surgery for arm and leg pain works fantastic. Okay, it really does. Cauda equina syndrome is one of those curses of doing a simple surgery on the back, like a lumbar lamia or something. Close them up and then they can't feel their perineum and their bladder's full and they're losing stool and everything else, 4 hours after surgery. They got a cauda equina syndrome. What they did was form an epidural hematoma from the surgery that compressed in on the cauda equina, the horsetail. The part of the spinal cord stops at T12, and from that point on, it's all peripheral nerves that go down through the canal and exit as they go down. And it puts pressure on them, and the sacral nerves, for whatever reason, are much more sensitive to pressure than the ones going down your legs. So a lot of people, if they get that, a lot of them lose bowel and bladder for life, even if you catch it. But the earlier you catch it, but if they say they're numb in their perineal area, trust them. If you put a Foley catheter in and they say, "You're really good, I couldn't even feel it," not so much. There's somebody over at St. Mary's that lost a couple $1 million because they put the catheter in and they documented, very good nurse documenting, put Foley in, drained 500 and clamped it and did it again in an hour or whatever. And patient said he didn't even feel it. He went home and came back paraplegic. He had a tumor that could have been taken out. It was a benign tumor. But so he got a really nice house and a van and everything else. But yeah, when you put a catheter in, people should be uncomfortable. Okay, that's a part of a neural exam. But now they're telling you can't put catheters in. Putting diapers on aren't going to cause anything. No, it's fine. Okay, in the anterior cervical fusions, basically they go through the front, take the disc out. They can see the nerve, clean it out, put a piece of bone in, and put just a bone on. Good. We had one rebleed in the last year. It's probably the only one in 10 years. Oh no, 2. There was 2 in the last 10 years here, where it actually started bleeding and started bulging out of the neck. And the surgeon likes to know, so they can open that up and stop it. And you can lose the airway. If they say it's getting so tight they can't breathe, see if they can talk. If they can talk, you're probably still okay, but you need to notify somebody. And usually they'll just do a cross-table x-ray, and they can see where the tissue is and how much blood there is. Because there's not very much tissue to swell down there. There's not a lot of muscle that swells up or anything. Okay, and the goal is to get pressure off the spinal cord or the nerve roots. And if they have myelopathy, if you see part of the diagnosis, cervical myelopathy, they probably are starting into a spinal cord syndrome, like a spinal cord injury, where they get hyperreflexive. You touch them and they jerk like crazy, and when they walk, they can't tell where their foot is. The proprioception isn't there. They start walking like Frankenstein and everything else. So they have myelopathy. There's all kinds of grades of myelopathy. Usually when they call it myelopathy now, they'll take an MRI and they can see a swelling down the middle of the cord where the canal's real tight or where there's a big bulge from the disc. They can see that in the spinal cord, they can see a white area where it's starting to swell. And you just get in and take it out. Most of them they never come back to 100%, but they come back to 90% if you catch them early enough. But it's a slow growing spinal cord injury. Okay, spinal cord injuries, just so we look at the spinal cord in itself. There's partial spinal cord injuries and complete spinal cord injuries. Okay, complete, the spinal cord is severed. Okay, and it's frequent at C1, 2. It'll actually sever and pull away from the brain. It'll actually rip apart, or gunshot wounds and all kinds of stuff. But you can have a complete spinal cord injury. Absolutely, your spinal cord will never do anything again except for work all day, every day. But it won't coordinate with your brain. Okay, so what happens is they go through spinal shock, they become flaccid, and that's when you will see them in the hospital. Within hours after having the complete spinal cord injury, but they'll still be moving in the meantime. They'll still be hyper-reflexive and everything else. A reflex, to get a reflex, you have to hit, the message has to go up to the brain. The brain has to say, it's just that person's hand, let it jerk. But there's no connection, and so you get hyper-reflexive on everything. Okay, so that's the complete cord syndromes, and they can't do anything with them. What they do is they treat them symptomatically. They're wheelchair for life and everything else, and usually they're really high. Is where most of the action gets. And then the partial cord syndromes. If you get an anterior spinal cord injury, like you switch, and your head goes back too far, and it stretches your spinal cord, and it comes back. You can tell what they have very easily, and this will change the way you examine people with traumas. They lose motor control below the injury. Okay, they're only going to lose the motor control. They still have all the sensation. Okay, they'll lose motor control. Sometimes they'll get some replacement, but they have their arms, everything feel great. They just can't move them. And if it's down lower in the back, everything else is like, and they can feel their legs, but they can't move them. Okay, so that's the anterior cord. The motor is in the front. That's the way to remember that. Motor's in the front of the cord. Okay, posterior cord syndrome, you lose sensation down. And that's a forward injury. Stretching forward, and you're stretching on the back end of the spinal cord, and it comes back. Okay, so you lose sensation, but you got motor. Now, what's better? I don't know. Okay, and then there's central cord syndrome. And central cord is one that occurs frequently, and you'll see them walking around. They have zero motor function in their arms. Their arms are dead, but their legs are fine. And they can walk. We had a guy in the vent unit, I don't know if you remember, there's a guy in the vent unit who used to cruise around the hospital, he used to cruise the neighborhood. And he could breathe enough to be off the vent for a couple hours, and every time it was nice out, he'd get outside and walk. Then get back up, get put back in the ventilator. From a central cord injury, couldn't use his arms for anything, walking. Most of us test the legs and we say, oh, the feet are strong, well, the cord's okay. Nah, not necessarily. If the arms don't move and the legs do, there's damage deep inside the middle part of the cord. Okay, and then there's the lateral cord injury, or the Brown's cord, where somehow one half is cut through, and they happen very frequently when people used to go after each other with swords and they hit them in the neck. You couldn't get all the way through, and you sever part of the cord. They'd have sensory on one side and motor on the other. Okay, and that happens in some accidents, some weird accidents. Yeah, but yeah, they sensory motor. It's not on the same side. And most of these people don't recover real well. The anterior cord, if it's in any injury below C4, you can keep your breathing. You need your intercostals for breathing. If it's below C4, you can maintain your breathing. At C4 and higher, you're more likely to be vent dependent, because all the innervations that come down for the intercostal muscles and stuff. So you become a diaphragm breather. Your diaphragm tightens up and sucks air in, tightens up and sucks air in, tightens up and sucks air in. And you can get by with that if it's down below C4. Every time you have an injury, they'll say, oh, it's a C5 injury, the person will get back to being like he had a C6 injury. Because you'll gain one level of function back, because it's the peripheral nerves along the outside that are in the process of exiting to go out to your arms and stuff. So if they come in looking like a C4, they'll end up being a C5. The biggest difference, if you can be a C5 to a C6, you can be independent. because you can get your triceps back. And then you can move. If you can't, otherwise your biceps are just coming up with nothing against it every time you do it. Every muscle has an opposite, so your tricep is opposite of your bicep. So when you're moving it, you're loosening this one, tightening this one, loosening this one, tightening this one. That's what you do all day. That's how your muscles work. They're all opposing each other to keep you standing upright, sitting upright, and those kind of things. So, let's see. And the medical problems that you guys will see is probably Guillain-Barré, or the creeping paralysis is what they used to call it. Sometimes they end up being permanent. Sometimes they don't. Guillain-Barré is a lot of damage to the peripheral nerves, not to the spinal cord, but to the peripheral nerves close to the spinal cord. Okay, the MS, when you get the MS, it's very sporadic. You spot here and there where you get a plaque in your spinal cord or your brain. Some people only have spinal cord MS. Most people only have brain MS, but you can have it any place in the tract. And the one that we will probably see, I've seen it probably one a year every year, is transverse myelitis, where somebody's had a viral disease, 3 weeks ago, and they think they got better, and they start feeling weak, and they come in, and usually only half of their spinal cord will work, and it's usually permanent, and it's usually probably from an infection, a viral infection. And I think usually it's a viral infection, then an injury in that area where you fall and you bump something and you stretch and it swells up and it hurts. And I think they really haven't got a good solution for it. But transverse myelitis is a very serious thing. You guys they'll be doing everything in the book. They'll be doing steroids, they'll be doing IVIG, they'll be doing dialysis, they'll be doing anything they can to try to clean the system out to prevent the cord from becoming completely dead. But there'll be like a partial cord injury. The front, back, maybe a little bit on the sides. I haven't got anything else. Anything for you guys? Any questions? Did I talk fast enough? Or should I talk faster next time? Okay. Being a French with a Polish wife, I had to do something. Any questions? Thanks. Thanks for doing such a great job. You guys are really good. I couldn't do it.